Hi everyone. Well, continuing in our H's and T series, the next T up, tension pneumothorax. And this is a biggie because this is your opportunity to jump in and save somebody very quickly, very reversible. Let's talk about a tension pneumothorax. First off, what is it? So pneumothorax, air in the thorax. What's happened is the lung has broken. The lung is essentially popped. Air is leaving the lung and beginning to collect in the pleural space. That's the problem. Now, what can happen is the hole where the air is leaving the lung can sometimes create a one-way valve. So air leaves the lung, collects in the pleural cavity, but it can't get back into the lung. And it starts to build up pressure or tension. So now what's happening is this pressure building up, this tension is pushing all the structures toward the middle. Now, what's lying in the middle? The big one is the vena cava, blood returning to the heart. Remember, the pressure in the vena cava as it's coming back to the heart is very low. In fact, right before it hits the heart is like 5. It's not even a systolic and diastolic anymore. It's one number, 5, and it's very, very low. So this pressure pushing on the vena cava, blood returning to the heart, can be completely compressed and kinked off. No blood returning to the heart. And that's what kills people in a tension pneumothorax. The pressure builds up, compresses the vena cava, no blood return to the heart. So, the fix. How do you treat a tension pneumothorax? We have to decompress that chest. We have to create an opening and let that pressure escape and get the pressure off the vena cava. Now, here we have a 3-inch 12-gauge needle. It's a very big needle because I have observed that some Americans have put on a little weight. So you may have just a lot of body to go through. Better to start with a big needle. What are we shooting for? We're shooting for the second, third intercostal space over the top of the third rib. How do we get there? Well, starting mid-clavicular, start at the clavicle, you cannot feel the first rib. You won't be able to feel it. In fact, the first rib that you can appreciate if you push down and feel, that's the second rib. So the first rib you can feel under the clavicle is the second rib. Drop down to the next rib, that's the third rib. And you're gonna place the needle right over the top of that third rib, mid-clavicular. That will decompress the chest, hopefully. So you do this, and you'll always hear, you'll hear the sound of air rushing out of the chest. I've never heard it, mostly because every time I've done this, it's been in a loud environment. I've never heard that. So how do you know it worked? Your patient should get better pretty quick. Pulses should return pretty quick. And I mean within 10, 15, 30 seconds tops, you got a pulse back. If not, it didn't work. If the patient's not getting better, it didn't work, put in another needle. Just move maybe half a centimeter to the right or to the left, but still over the third rib, and dart your patient again. Put another needle in there. I've seen patients come in with 3, 4 needles on both sides to achieve decompression. That's what you have to do. If it doesn't work, put in another needle. Now you have to make sure you're going over the top of the rib and not into the rib. You can see on this x-ray here where the needle kind of got caught on a rib and it got kinked. So you should, when you're inserting this needle, have no resistance. You shouldn't be hitting bone. Nice and easy over the top of the rib. And we go over the top of the rib because we want to avoid the bottom of the rib, where you have nerves and blood vessels following along the margin underneath the rib, so we want to avoid that. So always over the top of the rib. Okay, another technique for finding the landmarks for pleural decompression. You can start at the sternomanubrial joint, right, where the sternum meets the manubrium. This is also the angle of Louis. You can start right here. And if you work lateral, coming out to the mid-clavicular area, you should be right over the top of the third rib. So that's another technique. I like just starting here and feeling ribs down. Fine, either one is an acceptable technique for finding the insertion site for pleural decompression.
Air in his chest, it's crushing his lung.
Better, man? That feel better?
Okay, now who is likely to develop this particular T, the tension pneumothorax? Spontaneous pneumothorax, not necessarily tension, just a simple pneumothorax, and that's where air comes out of the lung into the pleural space, but it's allowed to get back into the lung, so it never builds up any tension. That's a simple pneumothorax. Tall, thin, high school age boys have been known to develop spontaneous pneumothorax, but of the patients that I've had to decompress, all of them had one thing in common. Now that I think about it, every patient I put a needle into had one thing in common. And what was that thing? Survey says? Yeah, positive pressure ventilation. Every single one of them. So if your patient is intubated, they are suspect to develop a tension pneumothorax. The last patient I flew in my helicopter developed a spontaneous tension pneumothorax right before we were getting ready to leave. All of a sudden, the high pressure alarm went off on the ventilator. I took the patient off the ventilator. I went to bag him. He was a brick. Couldn't get any air into him. I listened. One side, absent lung sounds. Can't get air into him. Immediate pleural decompression. And I happened to have the needle right in my pocket, pulled it out, decompressed, and after a few breaths, he became more compliant. Okay, so signs and symptoms of a tension pneumothorax. Well, profound dyspnea, the patient can't breathe. Tachypnea, they'll probably be breathing fast. Hypotension can develop. Remember, if it compresses on blood returning to the heart, that can cause hypotension. Jugular vein distension can occur. I like the tracheal deviation one, although I've never actually seen it because I never made it past the part where I can't get air into my patient part of my clinical assessment. I've never seen tracheal deviation because I was never looking for it because I got stuck at I can't put air into my patient. Do you know how far you got to mash stuff over to actually get the trachea to deviate? Look at this. Holy smokes, we really shouldn't see that. Maybe that patient is tolerating this very, very well, but we should never see that on an X-ray, of course. I'm Mark, thanks for watching. See you in the next video.